Alright, hey, how's it going, everybody? Welcome back to another episode of Pathagonia. This is Cole. So, tonight I'm going to go over tumors of the gallbladder and bile ducts. It's kind of another short episode similar to the one I just did on appendix, sticking with the GI theme, and let's just get to it. So, like any other area in the body for the most part, in the gallbladder and the bile ducts, you can have benign and malignant entities. So some of the benign tumors that you can see in the gallbladder and bile duct is, we'll start with bilin, or biliary intraepithelial neoplasia. This is a non-invasive in situ dysplastic epithelial lesion within the biliary tree or gallbladder. Can be low grade or high grade. And here you can see this low grade bilin. You can tell those nuclei are a little abnormal. They don't look monotonous, they look kind of dysplastic, and they are in fact low grade dysplasia. You can also have, in bilin, you can have chronic inflammation. This can happen with gallstones, primary sclerosing cholangitis, or parasite, which can induce mutations, lead to dysplasia, and cancer. So what could start out as cholecystitis or some inflammation could eventually lead to dysplasia and cancer down the way. So molecular underpinnings of bilin is going to have KRAS mutations, are seen in about 40% of cases. TP53 mutations are a late event in high-grade bilin, and we'll get to high-grade in a moment. And you have two-tiered grading system, as we'll show below in the table, and you grade the area of worst cytoarchitectural atypia. So the architecture can be flat or micropapillary. It can colonize peribiliary glands and Rokitansky-Aschoff sinuses, and don't confuse that for invasion. Some factors that are favoring reactive atypia versus dysplasia are cellular atypia is worse deeper in the epithelium, and it matures as you approach the surface. Generally, elsewhere in the body as well, like I'm specifically thinking of cervix. Whenever you have dysplasia, but you have maturation, or you have maybe some nuclei in the basal layer that look a little abnormal, but as you get closer to the surface, the cells mature. That's typically a sign more of a reactive change than dysplasia. In reactive atypia, you can have nuclei with fine chromatin and a gradual transition from normal to atypical. Neoplastic processes often have an abrupt transition. So here are some pictures of high-grade bilin, and you can see this looks, when you compare it to the low grade is still looks like a mucinous surface or an epithelial lining. High-grade bilin architecturally and cytologically just looks very atypical and worrisome. So I'll let you review this chart on your own, but it could be a good thing to reference, just comparing the features that you may see in low-grade bilin and high-grade bilin. So I don't think it would be quite as helpful for me to just read it off. Probably would be best for you to reference it on your own and take notes. But of note, on cytology specimens, such as a bile duct brushing, the distinction between invasive and non-invasive disease cannot be distinguished. So bilin 3 appears identical to invasive carcinoma on a bile duct brushing. And outcomes, if it's confined to the gallbladder, it's cured by surgical excision. However, this can be a field defect with multifocal disease throughout the biliary tree with regional recurrences. All right, moving on, we've got intracholecystic papillary neoplasm. Essentially an IPMN, but in the gallbladder. So, an intracholecystic papillary neoplasm is a mass-forming, grossly visible, non-invasive neoplasm arising in the gallbladder mucosa, versus bilin, which is microscopic. This kind of reminds me of IPMN versus PANN, where IPMN you can see grossly, PANN you cannot, it's smaller. So same concept, right? Different system, but all of pathology has its rules and things that translate to other systems, which is why we love it, and that's why we study it. So in intracholecystic papillary neoplasm, you can have intraluminal growth of back-to-back epithelium with primarily papillary architecture, as the name suggests. Sometimes it can be tubulopapillary. You grade the dysplasia using the same criteria as Bilin, often adjacent to Bilin with frequent KRAS mutations. And there are 4 morphological patterns, often intermixed, with no current clinical significance. Those are biliary, which is the most common, with cuboidal cells with clear to pink cytoplasm, enlarged nuclei and frequent nucleoli. Gastric, which resembles foveolar cells, with tall with abundant apical mucin. And intestinal, which resembles a colonic adenoma. As well as oncocytic, which is the least common, with abundant eosinophilic granular cytoplasm. An invasive carcinoma is identified in about half of the cases of intracholecystic papillary neoplasm, especially biliary type with high-grade bilin. So you want to sample these completely and extensively. Intraductal papillary neoplasm of the bile ducts, biliary IPMN. This is grossly visible papillary lesion, predominantly growing in the bile duct lumen, versus bilin, which is microscopic, not grossly visible, as we already mentioned, can cause biliary obstruction, duct dilation, and it can secrete abundant mucus. There are papillary fronds with fine fibrovascular cores covered by cuboidal or columnar neoplastic epithelium with variable cytologic atypia, and the grade is based on the area of the worst atypia. So some risk factors for an intraductal papillary neoplasm of the bile duct are primary sclerosing cholangitis, liver flukes, and molecular is going to have KRAS mutation leading to low-grade dysplasia, which can have P16 loss, TP53 mutation, which can lead to high-grade dysplasia, and invasive carcinoma. So there's a couple molecular pathways, KRAS and TP53. You can subgroup the same as above in the ICPN, but they're often mixed. The outcome, about 50% have an associated invasive component, so you want to sample these well also, and still better prognosis than conventional cholangiocarcinoma. From my experience, when I've seen entities and sign out any kind of dysplasia, even if it's like low grade, pretty much definitely want to make sure you submit the whole gallbladder. They're typically not very large specimens anyway, so it's good to be thorough and make sure that there's nothing more worrisome. Alright, next up we've got the pyloric gland adenoma of the gallbladder. This is a non-invasive benign glandular neoplasm of the gallbladder composed of mucinous glands with pyloric to Brunner's gland features. They're small, tightly packed, bland-looking glands with abundant pale apical mucinous cytoplasm, peripheral nuclei, and minimally interfering stroma. And some glands may be cystically dilated and can be pedunculated or sessile, and rarely can have superimposed high-grade dysplasia or carcinoma. Alright, moving on to malignant tumors that can be found in the gallbladder and extrahepatic bile duct. So of course you can have carcinoma of the gallbladder, and this is a malignant epithelial neoplasm in the gallbladder arising from the biliary epithelium. It's the most common biliary tract malignancy, most frequently occurs in older women with long-standing gallstones, and the tumors are most often located in the fundus and flat, and signs and symptoms overlap with cholelithiasis, so it's often diagnosed incidentally. Risk factors for carcinoma of the gallbladder include gallstones most commonly, primary sclerosing cholangitis, certain regional SNPs, and inflammation. So you can have that chronic cholecystitis, which leads to calcifications, which leads to a porcelain gallbladder, which can lead to Bile, and then carcinoma. Most cases are associated with surrounding dysplasia, so if you find dysplasia, sample the gallbladder well to see if there is an occult carcinoma. The molecular for gallbladder carcinoma, there's frequently CTNNB1 mutations, which is associated with beta-catenin, sometimes HER2 amplification or MMR deficiency. And there are subtypes, just to make it more complicated. That's what we love to do in pathology, is to have subtypes for everything. So you can have biliary type adenocarcinoma, which is the most common subtype, similar in morphology and behavior to pancreatic ductal adenocarcinoma. There's infiltrating tubules lined by cuboidal cells in the desmoplastic stroma. And there's also intestinal type adenocarcinoma, which resembles colonic adenocarcinoma with tubular configuration with columnar cells with elongated pseudostratified cells, and rarely, but must rule out a metastasis. You can also have mucinous adenocarcinoma, where over 50% of the tumor contains abundant extracellular mucin, as well as poorly cohesive carcinoma, where individual cells infiltrating diffusely through the wall, including signet ring cells. Other subtypes: clear cell carcinoma, squamous cell carcinoma, adenosquamous carcinoma, and it can be hard to tell dysplasia involving a Rokitansky Aschoff sinus from invasive tumor. Invasive tumor glands are often smaller glands with irregular contours and increased cytologic atypia. In contrast, RA sinuses, Rokitansky Aschoff sinuses, are often larger, dilated, and have round contours. And the prognosis depends largely on the stage. So if it's early, not yet muscle invasion, so PTIS, T1A, or T1B, it has a good prognosis. If it's advanced into or beyond the muscle, so greater than or equal to PT2, that is considered aggressive with a worse prognosis. Note, PT2 is subdivided by if the tumor is on the hepatic or peritoneal side of the gallbladder. If it's on the peritoneal side, it's a PT2A with a relatively better prognosis. If it's on the hepatic side, it's a PT2B with a relatively worse prognosis. And here we have some images of gallbladder carcinoma. Next up, we've got carcinoma of the extrahepatic bile ducts. So this is a malignant epithelial neoplasm arising in the extrahepatic bile ducts. Most frequently, adenocarcinoma, which we all know as cholangiocarcinoma. Klatskin tumor is a perihilar tumor occurring at the confluence of the right and left hepatic ducts. Cholangiocarcinomas, or carcinoma of the extrahepatic bile ducts, often occur in older patients, and they present with obstructive jaundice due to the location of the tumor. Risk factors include primary sclerosing cholangitis, liver flukes, choledochal cysts, and gallstones. There's two precursor lesions to carcinomas of the extrahepatic bile ducts, and that is Bile and intraductal papillary neoplasms, both of which we've already reviewed. And the molecular for carcinoma of the extrahepatic bile ducts is the early KRAS mutations and frequent late TP53 mutations. Most carcinomas are pancreatobiliary type. They resemble pancreatic ductal adenocarcinoma with widely spaced irregular glands and small tumor clusters infiltrating through desmoplastic stroma, with frequent perineural and lymphovascular invasion. Overall, there's a very aggressive tumors with a poor prognosis. Moving on, we'll talk a little bit about the cytological diagnosis of adenocarcinoma, and then we'll look at the images. So since it is so closely resembles pancreatic ductal adenocarcinoma, we use the same cytological criteria, which is best seen on Pap stain slides. So you want to see that 4:1 nuclear pleomorphism, that architectural disarray or drunken honeycomb, irregular nuclear contours, and single malignant cells. A helpful additional clue is a clearly neoplastic population and a separate, distinct, clearly benign population. If the person has primary sclerosing cholangitis or a stent, they may have considerable reactive atypia. So in these cases, it is often prudent to be more conservative and consider downgrading your diagnosis accordingly. Some ancillary testing on cytology specimens can be performed, such as next-gen sequencing, where you're looking for KRAS or TP53 mutations, as well as FISH, such as Eurovision, looking for aneuploidy. Note the distinction between high-grade bilin, or non-invasive, and invasive carcinoma cannot be made by brush cytology. You need the architecture to evaluate. And here we have some images of some cytological images of adenocarcinoma, where you can appreciate that architectural disarray or drunken honeycomb appearance. You have some irregular nuclear contours, as well as nuclear pleomorphism. So you could think this cell is at least 4 times bigger than this cell here, or 4 times bigger than this cell here. And then some advanced endoscopists can get tissue biopsies from the common bile duct lesions via cholangioscopy, such as with spyglass, often yielding small biopsies, which is very impressive. And that's it. That wraps up this short video. Again, thank you all for the support. I hope you're enjoying these. It helps me a lot to make them, and I hope you have a good night. See ya.